If you look at images of the heart with the coronary arteries, you'll notice that the coronary arteries are located on the outside of the heart. What you can't see is that they, is this for me? I was just sitting here, so I thought. You'll notice that they're on the outside of the heart. The heart is thick muscle. What you can't see is that these branch off into smaller and smaller arteries and smaller arterioles. And then the connections they have, the anastomoses they have, to ensure that an area gets well perfused. But understand something. It's still delivering oxygen from the outside of the heart in. So if we occlude one of those arteries, if we block one of those coronary arteries, or one of those small arterioles, if we block one of those small arteries, that means a portion of the heart muscle is not going to get blood. But the portion that's going to not get blood first is going to be a deeper portion. And that's going to be a bigger portion. And then as we go up through the layers of the heart more towards the outside, the area of infarction, the area that has died, sort of gets smaller and smaller. Does that make sense? That's why when you see a myocardial infarction, you cut the heart open, you'll see the area on the inside of the heart is always bigger. Because a lot of that tissue depended on oxygen diffusing through the layers. So if we cut off oxygen to one part of the heart, well then it's going to not diffuse as well to deeper layers and to the peripheral cells.
Seems like there's a lot of reason for the placement of a lot of stuff in our bodies. So is there a reason that our coronary artery didn't, like, I would expect that it would dip down and want to come to the outside layers if the inside is the most important, right?
What does the heart spend much of its time doing? Contracting and relaxing. That muscle has to be able to contract and relax. If you had blood vessels intertwining between it, the contraction of it would compress the blood vessels. So you don't want that to happen.
Makes sense.
And arteries are very specific. Arteries have a place to go. Artery is delivering blood from here to there. It's very specific. If you interrupt that pathway, that area down there is not going to get blood, it's not going to get nutrients, and what's going to happen to it? It's going to die. Veins, however, are not specific. Veins just sort of collect the blood as it returns. So that if you cut out a length of vein over here, the blood that would have traveled through that vein to come back up to the heart will just find another pathway back. That's why you'll hear about when they do things like coronary artery bypass grafts. They'll say, well, we'll take part of the saphenous vein and just use that up here. You would think, well, if you're cutting out a blood vessel from one part and moving to another part, doesn't that mean it's going to affect that area? Not really, not as a vein. Arteries are specific, veins aren't. Veins are, as I like to say, veins are vague. They're just collecting blood from wherever. Regular aerobic exercise increases the density of these blood vessels, hopefully, in the anastomoses. The right coronary artery provides blood for the right ventricle, the posterior portion, the intraventricular septum, and inferior parts of the heart. The left coronary artery provides blood to the left lateral anterior wall of the left ventricle, portion of the right ventricle, and ventricular septum. The left coronary artery, a portion of the left coronary artery, the left anterior descending artery, in fact. Have you heard of this? What do they call this one if that one gets blocked? The widowmaker. Yeah, because what's it feeding? It's feeding a big part of that left ventricle. Where's the left ventricle pumping blood out to?
The body.
The body. Places like
The brain.
The brain. Places like back out to the heart again. That's a big deal. Okay, so you can kind of see them sitting there. Notice again how the veins run right alongside the arteries. This happens a lot in the body, that arteries and veins sort of run together. And it kind of makes sense. Just like if you want to go, into Philadelphia, you take 95 north. If you're leaving Philadelphia, you take 95 south. They drive right next to each other. So it kind of makes sense in a lot of ways. The difference, however, especially when it comes to like the skin, Because arteries are under pressure, the body wants to protect them, so it puts the arteries deeper so that they don't accidentally get cut or sliced or nicked. Because of course they're under pressure and blood will come squirting out, whereas a vein, blood will just come dripping out until the clot forms. How does the blood then get from places like our feet up to our heart? Skeletal muscle contraction helps out a great deal. Obviously, there's going to be some of that pressure that had pushed it down through the capillaries and pushed it into eventually into the veins. But a big deal getting the blood back up. As we walk, as we move, the skeletal muscles contract and relax and contract and relax, and they help to push that column of blood up and up and up. The blood pressure falls too low, the valves that are in the veins close, until it comes time for that blood pressure to get up again. Also, as the right atria opens up, it actually does create a bit of a suction. It helps pull blood towards it. So those factors, but yes, skeletal muscle is a big deal with moving blood up from the heart. Remember, the heart has to keep up with a lot of things. Right now, I'm standing up. My heart is right about here. If I had one, it would be located right in this area right here. It's going to pump blood up against gravity to my head. It's going to pump blood parallel over to my shoulders, well, sort of parallel, and it's going to pump blood down to my feet. So it's like working with, against, and sort of in parallel with gravity, which means all these different parts in the body have to kind of pick up on this and decrease or increase the size of the lumen of those vessels to increase or decrease velocity, to increase or decrease pressure. There's a lot of information coming in. In our carotid arteries that lead up to our brain, right over here, there's a place where the common carotid artery branches off into two arteries, right? There is special pressure sensing cells that are located inside of this. And you guys may have heard of this. If a person's blood pressure is really, really high and they're concerned about patients stroking out, one of the things you may have heard somebody do is what's called a carotid rub or a carotid massage. Have you heard of this? Mm-hmm. Very dangerous. Don't try this. Because by putting pressure on that, it's tricking that area, those sensors, into thinking the blood pressure going through is so high that it sends a signal back to the heart and says, you know, lower the blood pressure. So it could actually be very dangerous. It's also something they teach you in special forces, right? So hit that area right in here, and that'll send a signal back to the heart, say, drop blood pressure on the person, will drop to the ground, like yesterday's wet newspaper. But don't try this at home. Say, look what Dr. Sturgeon taught me. Don't, oh, he's down. Not getting up. I'm going to jail. Cardiac muscle is autorhythmic, meaning it gets its own signal to contract. When do heart cells start contracting? In the uterus. In that new baby that's developing in the uterus. Do you have any idea, approximate time, those heart cells? The heart cells start contracting.
A couple of weeks. 2 or 3 weeks.
Okay, I have 2 to 8 weeks in here.
Extremely
about
early.
21 days. Now that doesn't mean the
3
heart
weeks.
is formed. That means the cells actually start contracting. That's pretty amazing. Because once they start contracting, once they start doing that, when do they stop?
When you're dead.
When you're dead. That's a long time. Every 0.8 of a second. You know, doing this contraction, relax, contract, relax. It's a long time. The nodal cells. These are the cells that make up the pacemaker and the area around, especially the sinoatrial main pacemaker of the heart. I know you've probably heard of people who've had pacemakers implanted. People get a pacemaker because their original one stopped working. And that pacemaker is located on the anterior wall, posterior wall, excuse me, back wall. Posterior wall of the right atrium, the SA node. And this is where the signal starts. This is where that signal begins that says, we need a heartbeat. These cells spontaneously send out a signal to contract. When this contracts, it sends this signal throughout the right atrium and over to the left atrium. Now remember, myocardial cells are unique. There are branched cells with those intercalated discs. So each cell that gets the signal to contract sends that message along very, very quickly. The sinoatrial node then sends a signal down to the atrioventricular node, the AV node. The AV node collects the signal, bundles it back up again, and sends it down the septum into this big bundle called the bundle of His, which branches off into these two bundle branches. They go down to the apex and then up the ventricles as the Purkinje fibers. So that is the transmission of the signal. So you'll notice how the apex of the heart gets the signal to contract a milliseconds just before this part of the ventricle gets the signal to contract, just before this part does, just before this part does, just before this part does. So the signal's traveling from the apex up, which means contraction is going to happen from the apex up, which is going to create a directional flow, which is going to push the blood up and out. We don't want the ventricles just to do this, do we? No, because what direction is it going to push the blood? Every direction. Also, it's going to have a very unique suction effect. You get one of those suction cups, you stick it on a glass. How many times do you stick it on? Once, and then it's stuck. Because if you try to pull it off, it's stuck there, right? As compared to if you rolled it on the glass, it wouldn't stick, right? So we're going to see this ventricle contracting from the bottom up, pushing the blood up and out. The SA node sends the impulse to AV node before the AV node can send a signal. Understand there's also specialized cells around the SA node. There are other nodal cells that are around there that can kick in, that can help boost the SA node. That's sort of a backup if the SA node isn't quite strong enough. But if it's really too weak, then we need to create a new one for the person. A slight signal delay allows for the atria to fill with blood before contraction occurs. That makes sense. AV to the bundle of His. Bless you. Divides on right and left bundle branches. Purkinje fibers carry the impulse to the ventricles. And you can see that here.
Does the septum contract at all, or is that just a stable structure?
There has to be contraction. It's still myocardial cells. There has to be. EKG. Why do we call it an EKG if there's no K in electrocardiograph?
Sure.
Good. Das ist sehr gut. Really? Normal EKG has 3 distinct waves. You've seen this before, everybody knows this, right? Are you familiar with the EKG waves? No, I missed the first one, didn't I? Am I familiar? Am I familiar? Okay, well, we'll throw it off a little bit there. The first one is what? And what does that correspond with?
Contraction of your atrium.
Not contraction. You can't see contraction. This is physiology. You can't see contraction.
Depolarization.
This is depolarization of the atrium and of the SA node, simultaneous. So it's SA node depolarization and right and left atrial depolarization. Not contraction. Contraction happens here. You can't see contraction on EKG. Then this is the Q, R, S, And what does that correspond with?
The depolarization of the ventricle.
Ventricular depolarization. Okay. And then the final T wave corresponds with what? Ventricular repolarization. Why don't we see atrial repolarization?
It's happening at the same time.
Well, two reasons. One, because it's covered up by the QRS complex. Two, it would be really, really small. Just look at the size of the ventricular repolarization. It's huge because of all this muscle. And look at the size of the depolarization. It's much, much smaller. The repolarization of the ventricles is much, much smaller than the depolarization. Well, the P wave, the atrial depolarization, is pretty small to begin with compared to the ventricular depolarization. So what would the repolarization look like anyway?
Really?
It would be really small. So even if it wasn't hidden, it would be small. Okay. Any other waves? U wave? Have you heard of the U wave? What caused the U wave?
Isn't that a premature contraction or something? Not contraction, because we can't see that, but
Yeah, don't say that. No.
no.
No. Nobody knows? Oh my god, you guys don't know this. I found something you guys don't know. Holy cow, I'm not telling you. No, I don't know. I don't know. Well, that's because nobody knows. Often it's associated with actually bradycardia. Like really low heart rate.
Where does it Google?
After the T. Yeah. Watch, you're going to prove me wrong. They just found out like 20 minutes ago. Yeah, we know exactly what it is.
I'm looking at Wikipedia. I won't be on that.
It's Ebola. It's the Ebola wave. Did you hear today, somebody asked me today, Surgeon, is this true? Which is always, where'd you hear it? It's on Facebook. Okay. That's all you need to tell me. No, it's not true.
Wikipedia thinks it is thought to represent the repolarization of papillary muscles or Purkinje fibers.
That's not true.
Doesn't sound true.
I'm sorry?
Doesn't sound true.
No. Wikipedia, really? Maybe that is it. Okay, so on Facebook, apparently somebody had read an article that a doctor, and I'm going to use air quotes again, a doctor had written that marijuana will keep you safe from Ebola. Yeah. Which makes perfect sense because they said it also has antibacterial and antifungal properties. So that's wonderful because we have antibiotics that don't have antibiotic and antifungal properties. We have no antiviral medications that have antibiotic and antifungal properties. Yet this apparently will do all three. Probably cure gout and depression. Well, definitely depression. What about glaucoma?
Say it helps with glaucoma.
How?
I have no clue.
What's the mechanism of action?
They're too high. They don't care anymore.
They don't care that they're blind. No, I don't know the mechanism of action actually. But it does work. There's two things medical marijuana is approved for. Do you know what those are?
Glaucoma?
What about cancer patients specifically? Yeah. It is specifically for anorexia that accompanies cancer patients, and treatment of cancer patients,
Chemo, radiation.
and glaucoma. Those are the only two things that it's actually approved for. But doctors are writing it off-label for all kinds of stuff. Depression, back pain, ankle hurts. Depression because they're out of weed.
So Merck report said it could be hypokalemia, hypomagnesemia, or ischemia.
Hypo or hyperkalemia?
Hypokalemia.
That's going to show in the T wave though. And it's going to depress it, isn't it? I'm going to elevate it. It's going to depress it, the T wave. All right. Hold on, there's a video that I'll put in after the break, but it shows it really very, very quickly. Again, what you're seeing here in this ECG, what you're seeing is not a contraction. What you're seeing is the physiology that's occurring. Depolarization or repolarization. What does that mean, depolarization?
Movement of ions.
Sodium channels.
I'm sorry?
It's movement of ions across membrane.
So you're changing
Negatively
the charge
charged.
across the membrane.
Yes, we're changing the charge across the membrane. Are we becoming more or less negative? Less. Becoming less negative, more positive, right? Yeah. We're becoming more positive, which means we're having more positives go in, less come out, right? We're having calcium, sodium going in, we're having potassium come out. That's kind of important because when we talk about classes of antiarrhythmics, there's 4 basic classes: class 1, class 2, class 3, and class 4. And class 1 are basically sodium blockers, class 2 are basically beta blockers, class 3 are basically potassium channel blockers, and class 4 are basically calcium channel blockers. So it's kind of important. All right. Use of immediate basic life support, transfer stabilized patient, cardiac arrest. Atherosclerosis. Atherosclerosis is a type of arteriosclerosis. Sclerosis means a hardening. So an arteriosclerosis is a hardening of the arteries. Atherosclerosis is actually a hardening of the arteries as a result of cholesterol buildup, actually in the layers. That causes the arterial wall to lose its flexibility. It's stiffened. It also becomes somewhat occluded. Anytime there's a defect in the endothelium, in the lining of a vessel, platelet's going to stick there. And anytime a platelet sticks there, it tells its friends to stick there. And then they stick to each other. And that's going to create a clot. Because that's what they're supposed to do. Anytime there's a defect in the lining of a blood vessel, platelets start sticking. That's why we tell those patients to take what drugs every day? 81 milligrams? Aspirin. Risk factors for atherosclerosis and also for coronary artery, there's coronary artery disease causing atherosclerosis. Hereditary should be up there too. Hereditary, age, gender, smoking, diabetes, obesity, hypertension, stress, drinking alcohol. Alcohol in large amounts, not in moderation. A little bit of alcohol is actually good. Not every break. Okay, a little bit more. No. Well, some things you can't change, like your age, your gender. Diabetes, type 1 is more difficult, of course. All you can do is really control. Type 2, you do have the ability, if you follow my advice, to stop it from happening, or at least reverse it, or at the very least control it. Something like stress is difficult to control because everybody has stress. What we have to do is understand what's really important, what's really worth stressing over. Most things aren't. Acute coronary syndrome is something like myocardial infarction, an MI, which is also known as a heart attack, and angina. Angina's that pain, right? They get it. Sometimes they get it at rest. There's different types of angina. Sometimes they get it when they're under exertion. Sometimes it's a combination. We can treat angina with nitrates, nitroglycerin. We can treat angina with types of beta blockers, even calcium channel blockers. But I think most people know nitrates, right? So what a nitrate's going to do? They're going to vasodilate. You know where they do most of their work? In which vessels? Actually, the veins. They do, of course, vasodilate the coronary arteries, but they do most of their work in dilating the veins. We keep most of our blood in our veins. About 60% of your blood at any given time is in your veins. So if we vasodilate the veins, what's that going to do for the pressure in the veins?
Drop it.
Decrease it. So it's going to decrease the preload, right? Because they have blood coming into the heart. It's going to decrease the amount of blood. So it's going to decrease the preload. No, you guys will learn that later on. Coronary artery occlusion. What's an occlusion? Blockage. ECG, you know about these? Blood tests. Why do we do blood tests? Cardiac enzymes. What cardiac enzymes?
After you have a MI.
After I have an MI? What after you have an MI?
Sure, why not?
Give me that. Monday night. Give me a heart attack. After a patient. Why? What? Why? Why?
Because it may not actually show up on your 12 lead.
So we're going to draw their blood. And what are we going to see? Troponin. What else? Yeah. What are the other ones?
That's the only one I ever hear about.
Lactate dehydrogenase. That's later, but yes, absolutely. Myoglobin. Creatine phosphokinase, CPK or CK, creatine kinase. You may have heard that. But there's different types of CK, and there's different types of LDH, lactate dehydrogenase. There's one specific for muscle, there's one specific for heart muscle, there's one specific for brain. So those are the enzymes that we look for. And one like, well, you're familiar with troponin, okay, so we'll go with troponin. One like troponin, that's going to be one of the first ones that leaks out. And it's going to peak. Do you know when it peaks? It peaks about, I'm sorry? I was going to say about 6 to 8 hours, you're going to see it peak. And then it's going to continue up to about 24 hours, right? What about CK? You're going to see that peak 12 hours up to about 24 hours or so. Lactate dehydrogenase, you can see a couple days afterwards. So what's this tell us? This tells us if anything happened, because why are these enzymes in the blood? What happened to the cells? They're dead. Stuff leaks out of dead cells. They otherwise, where would they be? Inside of the cell. They're not going to be in the blood otherwise. So when these cells die and stuff leaks out of them, it'll tell us we now have dead heart cells. What else is it going to tell us?
How much?
How long ago and how much? Yes, both. It's going to tell us when this happened, and it's going to tell us how much heart is actually damaged. Does that make sense? It won't to the patients. They'll understand putting these leads on their chest, sort of. Sometimes. Sometimes they do. Sometimes they go, is this going to shock me?
Why are you shaving?
Yeah. Yeah, why are you shaving me? Good one. Because you're hairy. All right. Treatment. What are we going to give immediately? At home, what are we going to give them? Aspirin. If you don't have aspirin at home, go get aspirin. They're at the dollar store. You can literally get aspirin for $1. Go get some baby aspirin, uncoated. Keep it around. It's amazing how much that little aspirin will do. Is it going to unblock a blockage? No. It's going to keep it from getting worse, right? It's going to keep those platelets from sticking. What it does is it's what we call suicide inhibition. It irreversibly inhibits platelets from sticking. And it does this, I say suicide, because any platelet that comes in contact with the aspirin is going to be switched off. It's not going to stick to anything for the entire life of that platelet, which is about 7 days. That's an important concept because you'll find out that you have a patient who is on aspirin a day therapy who suddenly needs their gallbladder taken out. And the surgeon is going to say, stop taking your aspirin, and when are we going to schedule this surgery? 7 days from now. Because when you're on the table and we're cutting you open, we want you to clot. We don't want you bleeding all over the place. Does that make sense? Okay. What's another medication people take so that they don't clot? Coumadin, also known as warfarin. And heparin, right. Heparin is Coumadin or warfarin is, right? Okay. What do people call these things?
Blood thinners.
Blood thinners. Do they thin the blood?
No.
No. Why don't they thin the blood? They are anticoagulants. The only way to thin blood would be either taking particles out of it or adding water to it. But we're certainly not going to add water volume to blood if we can help it, if they don't need it, right? That'll just increase pressure. So it's not going to do either of those two things. Heparin inactivates proteins that are in the blood already. So it doesn't take them out, it just stops them from doing their job. Coumadin stops the proteins that are released once the tissue is damaged. But it doesn't stop the ones that are already there. It stops the production, which is why we'll give patients heparin and Coumadin at the same time. And then we'll do those blood tests. Have you seen these? What are they called? Have you heard of these? What are they called, you know? People just use the initials.
INR. No.
That's a blood test, but that's not the one for Coumadin or heparin. PTT and PT.
Partial thrombin.
Activated partial thromboplastin time, the PTT, and prothrombin time. That way we can see once that heparin starts working, or once the Coumadin stops working, we can just continue to heparin. And then you just have the pill today, right? Make sense? Okay. I think we will see the coagulation cascade later on. If you've not seen this yet, look it up. It is extraordinarily complicated. You'll see a lot of Roman numerals and some names thrown in as well and a bunch of arrows going. But overall, I'll give an easier breakdown of it. I'll make it a little bit simpler to at least see the big picture. But it is extremely complicated. But why do the patients call these things blood thinners?
They don't clot.
Because they don't clot, and it looks like when they stick their finger, it looks like as the blood keeps coming and coming and coming, it just looks thinner. As compared to if you stick my finger, blood comes out and starts clotting, it looks thicker. That's why I got that name. Patients will call it this, doctors will call it this, nurses call it this, paramedics call it this. Stop calling it this. These are not blood thinners. What do we call them? Anticoagulants. That's their job. Hold on a second. What does nitroglycerin do? The nitrates? Vasodilates. What other medication could we give? What else could we give them? In general, oxygen. Why are we going to give them oxygen? Because what does their heart need that it's not getting enough of? Oxygen. We want to make sure all those seats on the buses are filled so that every red blood cell that's getting there is completely full. Does that make sense? Do you have a question or do you have a comment?
I have a question.
Can you hold the question for a minute? Because we're going to take a break in just a few minutes. I want to get through this couple of things right here. Percutaneous transluminal coronary angioplasty. Holy crap, that's a lot. What does this mean? We have a coronary artery that's partially occluded by some plaque. Well, we want to get the plaque out of the way. Not we, I don't do this. They will get a catheter. Bless you. Move it all the way up into position, following this coronary artery. Obviously, they have to use dyes and they have to use some sort of radiograph to see this happening in real time. Move this catheter into position. Right when they get to where the occlusion is, at the end of the catheter, there's a balloon that they will inflate. By inflating that balloon, it will literally smash the plaque out of the way. Now, if they want to make sure it maintains its patency, its openness, what will they do? They'll put a stent in, which, with the same catheter, in that same place, get it in there. Once they get this stent in place, it just springs open, and it'll keep that lumen nice and patent. I'm sorry?
Hopefully.
Hopefully. And they have really great success. I mean, you're talking several years. But if that doesn't work, or if they have to move on to the next one, then we go with the cabbage. This is a big deal. The ones I was a part of, these were 6-hour surgeries. And I wasn't allowed to touch anything. My job was to stand there, put my hands like this, and not touch a thing for 6 hours. Very interesting. Is the heart beating when this happens? No, we gotta stop the heart during the, they had to stop the heart, not me, I had nothing to do with it. Stop the heart, which means, had to go on a bypass machine, right, heart-lung bypass machine. So they have to work on a heart that isn't beating, which makes it a lot easier. Here we have a coronary artery, and we put a blockage right here. So what they'll do is they'll get part of that saphenous vein from the leg, cut a little piece out, start it here, and go right around the blockage. It's a bypass, just like on a freeway. Except it's not a freeway bypass, it's a coronary artery bypass. And they're grafting it in place. Coronary artery bypass graft. And the abbreviation CABG looks a lot like the word cabbage, so everybody calls it a cabbage. Now, if they had another one here and another one here, what would that be called? That'd be a triple bypass. You've heard these, right? This is a big deal. It's especially a big deal because 50 years ago, wait, what is this, 2014? 65 years ago, nobody operated on hearts. It was just the rare couple of occasions where anybody had any sort of success. A little bit of success during World War II with fishing some shrapnel out, but for the most part, the heart was off limits. You couldn't do anything with it. Now, of course, what we want to do, if we have a heart that's struggling, is we want to bring the oxygen demand down. That will help. That's why we decrease contractility and decrease heart rate, something like the beta blockers. But when we're doing surgery, how long do we have with this heart that is not beating if it doesn't get any blood? I'd say about 6 hours if I had to guess. Well, the reality is how close to that we want to come. We want to lengthen that as much as possible. So, of course, what are they going to do to the tissue? They're going to cool it down. If they cool the tissue down, its metabolism slows down, which means they don't use all their nutrients as quickly, which extends the life. Does that make sense? Okay. But, of course, if you cool the body down, what's the body do? It shivers. Why? It's cold to warm up. Isn't that why we shiver? And we end up using
Muscle relaxer.
even more oxygen than if we, we're just at rest. Which is why they have to use, exactly. And originally it was just like ether. It worked well. But you gotta, suppress the muscle. Okay, we'll take our break and then we'll come back.